Are you working in the ICU setting or plan to work in the ICU setting in the future, and you want to refresh or learn the most important tips for your code cool patient? Then stay tuned to get all of that knowledge from a seasoned trauma surgical ICU nurse. Welcome everyone to the Mama Nurse channel. I'm Vanessa, and here we discuss all things nursing, motherhood, and lifestyle. Make sure you leave a like on this video. Don't forget to subscribe before you leave, and leave a comment down below. Have you ever had a code cool patient, or are you just prepping for the future? Let me know down below. Code cool, aka therapeutic hypothermia treatment, is typically used after a patient experiences a cardiac arrest, aka a heart attack. Doctors will often order this treatment to medically induce hypothermia in order to preserve the brain function and reduce the risk of neurological damage. In order to be considered for this treatment, you do have to meet certain criteria. So let's go over a few of those. Your patient needs to be intubated, have no terminal disease diagnosis, has a systolic blood pressure of 90 or greater with or without pressors, no purposeful movement to pain, a core temp of greater than 32 degrees Celsius. You would want to have post-CPR with ROS and persistent coma. And last but not least, you would want to initiate this treatment within 5 hours of onset. These are the reasons why you wouldn't want to put your patient in therapeutic hypothermia treatment. If your patient has uncontrolled bleeding, a platelet count of 50,000 or less, or an INR of greater than 1.5. This increases the risk of bleeding, which would be detrimental to your patient if you initiated hypothermia treatment. If your patient has an advanced directive or DNR, if your MAP is less than 60 with pressors, your GCS is greater than 8, if there's any thought of the patient having major head trauma, you would need to get a CT prior to initiating this treatment to rule that out. If your patient has tested positive for drugs or had a drug overdose or is pregnant. If your patient is less than 18 years old, has active sepsis, or has had a previous bleed or abdominal surgery within the last 14 days. These are all the reasons why you would not want to initiate therapeutic hypothermia treatment. So to make this easier to follow along, I broke it down into phases. So I broke it down into 3 separate phases plus the initial nursing process phase. So let's get into it. So the initial process with getting your patient set up with hypothermia treatment would be they come in, they go to the ER. They would initially need to be admitted to the ICU, and they would have to consult the intensivist, who would be the one to manage this patient. It's always appropriate to notify the ICU charge nurse that you guys are initiating a hypothermia patient, because sometimes you have to make arrangements. As a previous charge nurse, I've had nights where I was getting a code cool patient and we would have to kind of change up the assignment a little bit, because these are typically one-on-one patients. And in order to make sure that it's safe for the patient, the nurse, and the unit, sometimes you have to do a little bit of moving around. So it is preferred that you notify the ICU charge nurse prior to that patient coming up. The intensivist would need to place a specialized catheter in order to initiate this treatment. Typically, they do it down in the ER before the patient even reaches the ICU, but sometimes it could be done at bedside in the ICU room. You would need some diagnostic tests and labs within 4 hours of the patient coming into the hospital. So some of those that you need are a stat 12 lead EKG, a stat chest x-ray, a stat arterial blood gas or ABG temperature corrected, and then also things like your phosphate, magnesium level, a renal panel, CBC and INR, troponin, lactic, urinalysis, pregnancy tests, and drug screen. Remember, if there's any thought of your patient having any head trauma, make sure you get a CT to rule that out. It would also be wise to get a type-in screen as well, just in case your patient needs blood. So let's begin with the induction phase. First, you would need to obtain your hospital supplied startup kit and system. Two that I've worked with in the past are the Arctic Sun and the ThermoGuard XP temperature management system. You would need to insert a rectal probe and a temp sensing Foley catheter in order to monitor your temperatures throughout the treatment. You do need temperatures from two separate sources, so a rectal temp and a core temp being your temp sensing Foley. Connect both of these to your monitor. So contrary to what we as nurses believe, we always want to clean our patients, make sure that they get their baths. During this treatment, you would not want to bathe your patient, not even your chlorhexidine wipes. You would need to insert an NG or OG and connect it to low intermittent wall suction. Keep in mind that you will need to do eyes and nose, vital signs, pulse checks, and neuro checks Q1 hour, and blood sugar checks Q4. Now let's move on to the cooling phase. For this, you may need to contact pharmacy or the doctor to make sure that it's completed correctly, but all of your IV medications need to be mixed with normal saline, no dextrose solutions. Once you initiate your hypothermia, you would need to document your temperatures, temp 1 and temp 2, every 30 minutes until your goal temp has been reached. Then you would record your temperature every hour. If your temperatures do not correlate within 1 degree Celsius for 2 consecutive hours, you would need to contact your physician because something could be wrong. So reach out so that you can find out what interventions to do next. It is crucial that the patient does not shiver, so you need to avoid shivering at all costs. Place socks on your patient's hands, feet, initiate a bear hugger, warm blankets, whatever you need to do to keep your patient warm. If these non-invasive interventions do not work, you can now try medications. Some medications that you could use are Demerol, acetaminophen, or buspirone. If these interventions do not work, you would need to initiate neuromuscular blockade protocol using your train of 4. Now let's move into the maintenance phase. So the maintenance phase is after your target temperature has been reached. You would now want your labs drawn Q6, a magnesium level, and a BNP at least, and then blood cultures Q12. This is specific to my hospital. Your hospital may be a little bit different, so make sure you check your protocol for this. Make sure you notify your physician with any cardiac changes, loss of O2 signal, or urine output less than 30 mLs per hour. Remember, even during the maintenance phase, no chlorhexidine baths. Now, when it comes to rewarming your patient. Rewarming begins 24 hours after your target temperature has been reached. The minimum time that you can rewarm your patient is 8 hours. The maximum is 24 hours. You don't want to warm your patient too quickly because that could reverse all of the treatment that you just tried to complete. So you can take it slow. You have up to 24 hours to do it, no less than 8 hours. You would want to rewarm at a rate of 0.25 degrees Celsius per hour. You would want to notify your physician once your target temperature has been reached. Get orders for adjustments of your RASS scale. DC your neuromuscular blockade, and consider catheter removal. You would not want your patient still on the neuromuscular blockade because you would want to see the progress. You would want to see the outcome, how your patient responded to the hypothermia treatment. So that's why you would want to get that discontinued. You would also want to remove that catheter because risk of infection. When it comes to the shivering tips, it's crucial that during the cooling process, your patient does not shiver because it could cause more damage. So that's why you don't want to do your chlorhexidine baths. It's only for the period of the treatment. Once it's complete and your patient is rewarmed, you can then chlorhexidine bath your patient. But prior to that, you would not want to because it could potentially harm your patient. Do you know of any other medications that could be used to avoid shivering? Or at my hospital, cold cool patients are typically a one-on-one. Are they one-on-one at your hospital? Or do you have other patients along with them? Let me know down below in the comments. Thank you for watching, and until next time, all love.